Preoperative preparation for an elective major surgery. The preoperative preparation of a patient is a critical aspect of ensuring a successful surgical procedure and minimizing complications. Here are the key points outlined in your provided information. Skin preparation. Shaving is no longer the preferred method for hair removal before surgery due to the risk of skin injury and infection. Depilatory creams or hair clipping are safer alternatives. A preoperative shower with an antiseptic solution on the day before surgery and on the morning of the surgery can help reduce the risk of skin infection. Diet. Patients are typically instructed to abstain from solid food for 12 hours before surgery and liquids for 6 to 8 hours before surgery. This fasting helps reduce the risk of aspiration during anesthesia. Purgatives and enemas. Preoperative purgatives or enemas are generally not required unless the patient has specific bowel issues or is undergoing colorectal surgery. Premedications. Benzodiazepines, such as diazepam, lorazepam, oxazepam, or nitrazepam, are commonly used as premedications to reduce anxiety and promote relaxation before surgery. They are administered orally and take effect within about an hour. Nasogastric tube. Routine use of nasogastric tubes is not necessary for many surgeries, particularly cholecystectomy. However, they may be required in cases of gastric outlet obstruction or intestinal obstruction for stomach decompression. Catheterization. Preoperative catheterization is indicated for certain surgeries, especially pelvic operations, and when monitoring urine output is necessary during and after surgery. Blood transfusion. Adequate blood reserves should be available in surgeries where significant blood loss is anticipated. Proper grouping and cross-matching of blood units are essential to ensure blood availability during the operation. Preoperative volume correction. Patients with suspected fluid and electrolyte imbalances should have these corrected before surgery to optimize their condition. Continuing medications. Some medications, such as corticosteroids, antihypertensives, digoxin, and levothyroxine, should be continued during the perioperative period. However, oral anticoagulants and aspirin are typically discontinued 5 to 7 days before surgery to reduce the risk of excessive bleeding. Prophylaxis against surgical infections. Prophylactic antibiotics are not needed for clean surgeries. They are recommended for clean contaminated and contaminated surgeries. In grossly contaminated cases, antibiotics should be continued in the postoperative period. Antibiotics should be administered before the skin incision to achieve therapeutic levels in the bloodstream. The choice of antibiotics should be based on the likely pathogens for a given situation. Prophylaxis against tetanus infection. Patients should be asked about their past tetanus immunization history, and immunization should be administered if necessary to prevent tetanus infection. Each of these preoperative measures is tailored to the specific needs and circumstances of the patient and the type of surgery being performed. Proper planning and adherence to these guidelines help ensure patient safety and reduce the risk of complications during and after surgery. The provided information outlines guidelines for tetanus immunization and prophylaxis against deep vein thrombosis, DVT, in the context of preoperative preparation and wound management. Let's recap these guidelines. Immunization for tetanus. Immunization history unknown or not immunized. 1. Active immunization. Administer 3 doses of adsorbed tetanus toxoid intramuscularly at 1-month intervals. 2. Booster doses. After the primary course, give a booster dose 5 years after the primary course and another booster dose after 10 years. 3. Tetanus-prone wounds. For wounds at risk of tetanus infection, administer a dose of human tetanus immunoglobulin, 250 IU, intramuscularly for passive immunization in addition to the tetanus toxoid. Fully immunized in childhood. 1. Minor or non-tetanus prone wound. If the patient has received the last dose of tetanus toxoid within 10 years, no vaccine is required. 1. If the last dose was taken earlier than 10 years, provide 1 dose of tetanus toxoid. 2. Tetanus-prone wound. If the patient received the last dose within 5 years, no vaccine is required. 2. If the last dose was taken earlier than 5 years, administer 1 dose of tetanus toxoid. 3. Tetanus immunoglobulin. If the patient is fully immunized from childhood, tetanus immunoglobulin is not required. Prophylaxis against deep vein thrombosis, DVT. The risk of developing DVT in the postoperative period can be influenced by various factors. Patients are typically stratified into risk groups, low, intermediate, and high, based on factors such as age, the nature and duration of surgery, presence of certain medical conditions, for example, jaundice, malignant disease, cardiac disease, and past history of DVT. Low risk group: anticoagulants are not required for DVT prophylaxis in this group. Measures such as graduated elastic stockings and early ambulation following surgery are recommended to prevent DVT. Intermediate and high risk group: prophylaxis against DVT may be necessary in these groups. Options for DVT prophylaxis include 1. Unfractionated heparin. 2. Low molecular weight heparin. 3. Graduated elastic stockings. The choice of DVT prophylaxis method depends on the specific risk factors and individual patient characteristics. These measures are important for preventing potentially serious complications such as deep vein thrombosis and pulmonary embolism in the postoperative period. The assessment of DVT risk should be performed by healthcare providers as part of the preoperative evaluation.